we've already talked a lot about stroke thrombectomy, so you guys know that it is definitely one of the things we offer that is quite important for patients to improve their outcomes. Just as a quick recap, of course, it improves significant functional independence, as well as improves mortality. Now, obviously, our our kind of landscape of stroke care had changed significantly with the initial set of thrombectomy trials, and a lot of these were kind of how we were identifying patients who are most appropriate for thrombectomy, those who do not have a lot of pre-existing cognitive or neurological deficits, those who have large enough of a stroke symptom, as well as, of course, a large vessel occlusion. But as Dr. Lewandowski had already mentioned, a lot of new studies has come out that have shown that other patients can also benefit from this, including those with, of course, a large infarct that you guys already heard about. So I would say that, of course, now the landscape for stroke has continued to evolve, and we're offering thrombectomy to more and more patients. He also mentioned that with patients with maybe more medium vessel occlusions, like M2s or A2s, etc., these are being looked at even more. And I think that is also going to be a subpopulation that hopefully we can better identify on who can benefit from this, but also technically how to better perform these studies. Now, touching on intracerebral hemorrhage, Dr. Singer already gave us a great talk on that as well. The things that I want to highlight are some of the similar points he had mentioned, which is that there is a significant amount of patients who have early hematoma expansion. And as he mentioned, it really, of course, impacts the mortality and outcome significantly. And a lot of these you guys have seen, a lot of times we get hemorrhages in a deep structure space, beginning with a thalamus, and that can track into the ventricular space. And that means that these patients can have the additive kind of neurological worsening with obstructive hydrocephalus that occurs. Now, we do know that risk factors for hematoma expansion is related to time of onset, because there is, of course, somewhat of a natural history, right? If, let's say, somebody literally develops an intracerebral hemorrhage in your ED waiting room and you get them to the scanner within minutes, of course that patient's going to have a hematoma expansion on your subsequent CT. But we also know that if they're coming in with a large hemorrhage and then these other risk factors that are, I think are quite intuitive, then those patients are going to have higher risk as well. Obviously, some of which we can modify and others we can't. But I want to point out the fact that potentially we should think about intracerebral hemorrhage the same way as ischemic stroke, in that we should determine when the patient was last more normal, right? Because then you can actually know how likely this patient may have further progression of their hemorrhage. And to that point, there's more and more talk about having a code ICH approach to managing patients with intracerebral hemorrhage, similar to the fact that we have such well-developed approach to ischemic stroke, right? And what does that mean? That means when the patient hits your door, you want to know when their time of last well is. You want to obtain your CT angiogram, because a lot of times you can't differentiate whether this is an ischemic stroke or a hemorrhagic stroke, especially if the patient's coming, with quite significant deficits. Then, of course, we want to aggressively control the blood pressure, like Dr. Singer mentioned, because we know that that can reduce the risk of hematoma expansion. Obviously, you got your CT thus far, you're going to consult neurosurgery to figure out if there's any sort of intervention that may be needed. And really, we're going to be looking at early and rapid and reversals of anticoagulants, as we also heard about. All of these to really try and limit that hematoma expansion to have a better outcome for these patients. And to the point of this code ICH, and this is now starting to become and going to be incorporated into metrics, at least in the US, for American Stroke Association, stroke center designations to kind of track how are we performing on these particular metrics. Now, I mentioned a few of these hemorrhage cases can have complications of obstructive hydrocephalus. And specifically in subarachnoid hemorrhages, a number of these patients do die before coming into the hospital, not just from the extent of their bleed, but also because of the hydrocephalus that occurs, and then that can subsequently continue to progress early on in their hospital course. So it's not uncommon. Unfortunately, I work in Maryland, which is not a very big state, but some of my patients may take up to 3 hours coming to me and as tertiary referral center, and by the time they have arrived to me, maybe their bleed burden is not so large in the case of a subarachnoid hemorrhage, but it's the untreated hydrocephalus that they herniate and die from. So I think that one thing that my residents and others who have heard me speak before is that I think it is very much within our responsibility, a purview to be able to identify hydrocephalus on the non-contrast head CT. At least I've also had the experience that it's not always mentioned by radiologists. So if you do see a dilated third ventricle, kind of in the center that's nice and round, that should not be the case. If you see dilated fourth ventricle, if you see really, of course, enlarged ventricles in general into the temporal lobes of the brain, then those are signs of hydrocephalus that you can treat. It also can be seen, of course, in intracerebral hemorrhage, and I want to point out that the image on the right is a purely intraventricular hemorrhage patient without really any parenchymal component. And by treating that hydrocephalus, by draining out the ventricular blood, the patients can do quite well. And so just because they become comatose may not mean that that's going to be the outcome they have. Obviously, how do you treat hydrocephalus without a surgeon to put a drain in for you? A lot of times we're using osmotic therapy, whether you prefer mannitol or hypertonic saline. I think most of the time in the acute phase you're treating using hypertonic saline because some of these patients also need volume resuscitation. You have many flavors of hypertonic saline. I have the luxury of also having very concentrated hypertonic saline, 23% in my ICU. And I don't know about you, some of the institutions that I've worked at say, oh my gosh, anything that's hypertonic, quote unquote, needs to go in the central line. That's not the case because we give ICAR with peripheral IV. And it's also been studied that even 23.4% hypertonic saline can be given through a peripheral IV, assuming you have a nice, large bore IV that flushes well. So I consider this as a quote-unquote brain code, and I will use whatever I have to give the medication I need to do to treat the patient. Moving a little bit onto seizures, we know that we have patients who come in, if they're still seizing by the time they're seeing you, they're probably in status epilepticus and probably also refractory, because a good amount of these patients have already gotten hopefully some treatments thus far. But unfortunately, we know that we still do not give benzodiazepines in an adequate dose. This came from the ESET trial that showed that a huge proportion of patients did not receive initial benzodiazepines at the recommended doses. And even cumulatively, let's say if you give to 2 and ultimately 8 total milligrams in an adult with lorazepam, that's not going to be as effective with seizure cessation. And this has been proven again and again and again, so hopefully our practice is going to shift, that we're going to try and give the appropriate doses of benzos early on and to try and avoid the seizures. This is just a reminder for the doses of lorazepam, midazolam, and diazepam if you really use those. But let's say if the patient is truly benzo resistant. Obviously, a lot of emergency medicine loves ketamine, and I think there's going to be more and more to come on this in that ketamine, because it targets a different mechanism and NMDA receptors. It's been shown in some of these observational case series, and in this particular case as a rescue medication in an EMS setting, to be quite effective in avoiding seizures. And so, obviously, these are not particularly the randomized controlled trial yet, but there's going to be an oncoming ketamine study, multi-center RCT that will look specifically at this. So hopefully we will get some, bigger data on the role of ketamine in refractory status epilepticus. I do want to touch on cardiac arrest, which is a neurological condition, because ultimately after you get resuscitation, the ongoing care of these patients does involve managing a component of their brain injury. Now, this is not to talk about all the hypothermia trials in cardiac arrest or such, but to point out that all brain injuries actually are often associated with hyperthermia. It's related to an inflammatory response, and that itself can be related with poor outcomes. You see some of these things, worse mortality, worse functional outcomes, longer latent stays. And that is across all brain injuries, whether it's hemorrhages, strokes, TBIs, and cardiac arrest. And the issue is that even if you're measuring body temperature, the brain temperature, when we have the luxury of invasive monitors like the brain tissue oxygenation monitor that also measures brain temperature is at least a degree higher than that body temperature. So worse outcomes and our core body temperature doesn't reflect true brain temperature. So treat fever seriously. And that just means that we want to at least avoid fevers and treat fevers. And again, as more information comes out of some of the cardiac arrest literature, we'll get hopefully more guidance on where is the role of hypothermia and such. Now, my final point is probably the most important procedure intervention we do in all brain injury patients. And that is the fact that there's a lot of nihilism in brain injury. And you can see here that of the 60% of deaths in severe brain injuries related to withdrawal life support, right? So what we tell patients' families on what the prognosis is affects their outcomes, right? And what we're finding out more and more is we don't truly know how these patients will do. And so a longitudinal study in ATTRACT TBI has shown that really by a year out from these severe TBI patients, severe and moderate TBI patients, a good proportion of them regain functional independence. And a number of these patients who appear to be in a vegetative state really regain consciousness. And I think more and more we're finding that even those patients with intracerebral hemorrhage, which is for a long time thought to be a disease process that we may not have much interventions for, which the upshot is that there may be more interventions that are coming out, surgical ones that we have not gotten to cover. But this is a good conglomeration of patients from 2 of the intervention studies that have shown that at day 30, these patients appear to have quite poor outcomes with MRI system 4 or 5, but you see that almost 100 days after injury, these patients ultimately can, a good proportion of return home. And so I think that it's not so much that we leave everything as roses and cheery, but it's more of the fact that we say that, if the wishes of the families are based on patients' known kind of preferences are to give a valiant try of aggressive medical therapy, that means we give a valiant try of aggressive medical therapy for whether it stays in the hospital or extended, because sometimes we do not know how they ultimately will pan out. So to run down kind of my top 10, you guys already heard, I think in ischemic stroke, certainly we're doing thrombectomy in large core patients, and we may consider, as we get more data, and median vessel occlusions. In ICH, consider getting your last known normal time to really assess who's at risk for hematoma expansion, and really consider a bundle of care approach in this code ICH that is coming out. In terms of all hemorrhages, be aware of hydrocephalus, which can really affect, of course, outcomes, and you have a role in identifying that and treating that, maybe with hypertonic saline with a peripheral IV. And status epilepticus, obviously, please give benzos appropriately early in terms of its dosage, and if they're truly refractory, maybe ketamine is going to be the thing we reach for as we get more data. And ultimately, if we are managing, in the case of post-cardiac arrest, that does mean active temperature management. We're really thinking about fever, avoidance of treatment of all acute brain injury, and of course, try to avoid early prognostication in neurological injuries. Thank you.